Hi everyone, so this is a PowerPoint of Are We Staying Up Late, which was done at the Bristol Children's Hospital on paediatric supracondylar fractures and their timing of surgery. So the audit was based around the BOST 11 guidelines for supracondylar fractures of the humerus in children. The 2 the timing of surgery. So number 2 is the injuries require urgent surgical treatment, ideally on the day of admission, but nighttime operating is not necessary unless it's indicated. And those indications for urgent surgical treatment include either an absent radial pulse, clinical signs of impaired perfusion of either the hand or digits, and evidence of threatened skin viability. So the aim was to assess the theatre time according to BOST guidelines across a 3-year period. This has already been done for the year of 2017, and we added the 2018 and 2019 data to this as well, and identify any operations that occurred out of hours and reasons behind the decision. Firstly, whether the rate of conversion to open increased after change in practice, following its presentation in 2017. And then whether there was a development of any neurovascular complications secondary to delay of surgery to the next working day. It's a retrospective study, so data was collected from January 2017 through to December 2019, as discussed. The cohort was identified through the theatre database and a PACS system. And then we included displaced extension type fractures, which were either Gartland type 2B and 3, which required surgical fixation. Reason for out of hours operating were examined for with notes using the Evolve system, which is what they use to record all the notes, and clinic letters as well as operation notes. So over the 3 years, 172 patients were identified. They had a mean age of 6 years. And there was a similar mix of type 2B and 3 fractures across the 3 years. You can see really with the number of patients staying largely similar across each year, the types of fracture actually remained largely similar as well. There were 4 Gastillo-Anderson grade 1 open fractures, 1 from each year, with 2019 having 2, and they were all operated on the same night. In terms of timing, in the 2017 cohort, there were just over 20% operated on out of hours. The actual number was 12 out of the 55. 4 of them had the appropriate indication as per the BOA guidelines, but 5 of them had no clear documentation in their notes of the reason for their out of hours operation. Following presentation, the number then fell to 15% in 2018, and then in 2019 dropped even further to less than 10%, with only 4 patients being operated on out of hours. All out of hours operating in 2018 and 2019 related to Gartland type 3 fractures. As this graph shows, you can see, so the green is in hours operating between 8 and 5, and then the yellow is between 5 and 10. With the red column indicating after 10 o'clock operating. And as you can see, generally over the 3 years, the green bars are all going in the right direction, i.e. up, and the yellow bars stay largely similar, but more importantly, the red bars are going in a downward trajectory, which is good. The reasons for operating out of hours, again, skin viability, nerve palsy, or an absent pulse, as we previously discussed, were all highlighted, and any reasons not documented. As you can see, in 2017 there were 5 patients not documented, but actually by 2019, following change in practice and ongoing data collection, we showed that people were actually, the documentation was improving as well. In terms of complications, there was no increase in the rate of conversion to open reduction in both 2018 and 2019, secondary to a delay in treatment. No patients developed preoperative neurovascular complications secondary to delayed treatment. And all patients with preoperative neuropraxia actually completely resolved regardless of the timing of their procedure, and there were no iatrogenic neuropraxias recorded. So, and this table just highlights this with in-house procedure, same day, next day, and then out of hours. In hours, sorry, not in-house. So to conclude, out of hours operating dropped from 22% in 2017 down to 12, and then 7, which was a significant improvement. And there was no increase recorded in the rate of conversion to open reduction or an increase in neurovascular complications. So this really is a clinical demonstration that delaying surgery in paediatric population of patients presenting with a displaced supracondylar fracture until the next day, in accordance with a lot of the literature, is both safe and actually cause no subsequent increase in complications. That's it for our presentation. So I will now be able to field any questions.